Total parenteral nutrition. You need to recognize that abruptly stopping or decreasing the flow rate of a TPN can result in hypoglycemia. So it should never be stopped abruptly. It should be weaned gradually. Potential complications of TPN, there's quite a few here, and they're broken down into categories. Under metabolic, you have the glucose intolerance. It's a very common occurrence due to the high dextrose concentration TPN solution for blood sugar to get very high. Administration of exogenous insulin is often necessary for someone who is receiving TPN, and it's usually only while they are receiving this particular fluid. Risk factors for glucose intolerance will include sepsis, stress, shock, hepatic and renal failure, starvation diabetes, pancreatic disease, some medications such as steroids, diuretics, and tranquilizers, and age, the very young and elderly, and the highly susceptible patients, and those patients with hypokalemia. Urine should be tested for sugar and acetone every 6 hours throughout TPN therapy. And serum glucose levels are determined daily unless the maintenance flow rate is achieved. And after that, then it would be twice a week. Hypoglycemia, rebound hypoglycemia, is defined as a serum glucose level of less than 50 milligrams per 100 mLs. Many patients are asymptomatic at this level, and it's only discovered through routine blood chemistry studies. Symptoms might be a headache or weakness, cold, clammy skin. You may see chills in the patient, thirst, tingling of the extremities or the mouth, hunger, apprehension, diaphoresis, decreased levels of consciousness, changes in vital sign, and all of these can progress to a seizure disorder if it's left untreated. It's caused by the abrupt termination of TPN or decrease in the flow rate of TPN. And then you have hyperglycemic, hyperosmolar, or non-ketonic coma that can result from unchecked progressive glucose intolerance. And if it's untreated, comatose state will lead to death. Reversal of this state requires immediate discontinuation of the TPN solution, aggressive fluid and electrolyte replacement, correction of hyperglycemia by insulin administration, correction of acidosis with bicarbonates. With electrolyte imbalances, these are either avoidable or controllable. They result from deficient amounts supplied in the daily fluid allowance or excessive amounts supplied in the daily fluid allowance. Electrolyte studies should be ongoing to determine electrolyte levels. Essential fatty acid deficiency can be detected both biochemically and clinically. Clinical signs and symptoms will be the dry or scaling skin, thinning hair, thrombocytopenia, liver function abnormalities, or an elevated BUN. By adding lipids to nutritional support, this deficiency can be eliminated. Sepsis. TPN patients are extremely susceptible to infection, especially fungal sepsis. It's usually caused by organisms at the catheter site that migrate along the catheter rather from inline contamination. Catheter sepsis typically appears as a low-grade fever for several days, progressing gradually to a high fever. In all cases of suspected sepsis, when fever appears, thorough culturing is necessary to determine the etiology of the fever. Nutritional IV lines should be placed specifically for the administration of TPN, and there should be a no in-use violation of the line for provision of other therapies. Catheter-associated complications. You have insertion-related. Placement can result in serious events such as a pneumothorax, a hemothorax, a hydrothorax, inadvertent arterial puncture, brachial plexus injury, a thoracic duct injury, a sheared catheter with distal embolization, an air embolism, or a catheter tip malposition. So you need to be particularly alert for signs of respiratory distress, pain, a slowly increasing hematoma, arrhythmias, any unexplained symptoms. And after insertion, you can see occlusion, damage or rupture, dislodgement, and catheter tip migration. And an air emboli can happen during tubing changes or an accidental disconnection of the tubing junction, or it can be through a tract left after catheter removal. So considerations when administering TPN. TPN site should not be used for any other IV therapy. Parenteral formulations before administration, make sure that you inspect the container for integrity and inspect solution for absence of particulate matter and turbidity. Do not add any medications to the solution. Observe the infusion rate guidelines and initiate TPN infusion slowly. Maintain a constant flow rate. Decrease TPN infusions gradually, and you should always use an electronic infusion device. If filtration is used according to facility policy, the delivery of the standard TPN solution, you should use a 0.22 microfilter. If you have a 3-in-1 solution, it should be a 1.2. And TPN administration set change should be accomplished again every 24 hours. The change should coincide with the hanging of new fluid. During change, the patient should be flat in bed, and they should be instructed to perform the Valsalva maneuver if the catheter becomes open to air. The catheter site dressing changes, they should be performed aseptically, and the routine schedule would depend upon the agency's policy. You can also change the dressing if the dressing becomes wet, soiled, or non-occlusive. Monitoring of the patient will be checking a fingerstick blood sugar every 6 hours and administering sliding scale insulin as ordered. Accurate daily weights, which should be performed at the same time of day using the same scale and the same type of clothing. Daily I&O monitoring should be scrupulously recorded. Monitor the patient's vital signs every 6 hours. Closely assess for signs and symptoms of fluid and electrolyte imbalances. The labs that you're going to be monitoring will include serum glucose levels, the electrolyte profile, BUN and creatinine, liver function, and lipemia clearance if lipids are administered, and closely assess for signs and symptoms of infectious processes. With lipid administration, you need to be, or the dosage and infusion rates will depend on the product concentration, the patient's age, and the state of therapy. The initial infusion rates usually are very slow for a limited period of time while you monitor that patient for any adverse reactions. Nursing considerations. You need to inspect the emulsion for separation or an oily appearance and discard it if those are present. Use non-PVC tubing supplied by the manufacturer. Lipid administration tubing should be changed every 12 hours to 24 hours, and make sure that you label that tubing. Do not filter lipids unless ordered. Do not retain partially used containers. Lipid administrations can be infused as a solo infusion or can be mixed in with the TPN through a Y connector. The precautions: the patient's ability to eliminate infused fat from circulation should be monitored, so lipemia must clear between your daily infusions. Contraindications will be disturbances in normal fat metabolism, pathologic hyperlipidemia, lipoid nephrosis, and acute pancreatitis if accompanied by hyperlipidemia.